Slides up so I can show them, right?
Through a class.
Yes, he will, Ben.
Good. Because they just disappeared.
Good afternoon. And welcome to the great Stop Retractive Orthodontics debate as conceived and executed by John Mew et al., the Mews in England. It's an honor to be with all of you today. My name's Brian Hockel, and I'm just giving a brief introduction right now, after which I'll be happy to turn the program over to Dr. Bill Hang. After Bill, then I'm going to have a brief say as I've got a video that I'm going to show to you, and then we're going to pause and have a break for some questions. I'm sorry, after I speak, then we'll have Ireland Bond speak, and she is a patient and give us a perspective of somebody who's had some retractive orthodontics. Then we'll pause for a panel debate, after which will be Barry Raphael and Mark Cruz to speak also about forward growth and its benefits, followed by Ben Eastwood, who will also discuss forward growth and its benefits, and Karen Bott. So we're looking forward to the questions you all answer online, and having some great minds help you figure out some answers to this today. So it's been framed today as the great debate to talk about stopping retractive orthodontics. So I thought I would just ask the question here. Actually, Bill, if you could put it back on my slides. So the question really becomes, this is both for the people who are convinced that it should be stopped and for people who are curious about whether it should be stopped or not. The question becomes really, why is retractive orthodontics bad? And I hope that's a question you'll be able to answer over the course of these programs. Really, three main questions. Can it ever be harmful to patients? And when can we be certain that retractive orthodontics will not be harmful? And finally, given what we now know, what should we do or should we not do? So very briefly, if retractive orthodontics has harmed even one person, then the answer to the first question is yes. So I know that's kind of anecdotal, but it's enough to really answer the question, is there a possibility? And if there are several people who have claimed to have been harmed or have seemed to have shown harm, then that could also be a possibility. So listen to this event, see if even one person has been harmed by retractive orthodontics. Secondly, if retractive orthodontics was a cause of harm, it'd be logical that if you reversed it, then that would be helpful to some people. So during the course of this event, see if even one person has benefited by the reversal of retractive orthodontics. Thirdly, are there studies that would support the mechanisms which would explain the harm caused by retractive orthodontics? And keep your eyes open for studies that they do indeed exist that could support the mechanism. And finally, Einstein and others have used what they call the Gedanken experiment, using logic, using your mind and a thought experiment to just ask, should limited tongue space pose a risk to the airway? Think through what the logical consequences of that are. There are many different ways we can answer this question, can retractive orthodontics be harmful? Secondly, when would we be certain that it will not, when can we be certain that it will not be harmful? This is really hard to prove, especially for an individual. Can you prove to me that retraction on this individual patient will not be harmful? No, you really can't. Maybe in hindsight you could, but what about looking into the future for the person? Can that really be proven? I would say never. So the third question, given what we know, what should we do or what should we not do? So the syllogism goes, retractive orthodontics can be harmful. We do not know when it will be harmful, therefore we should not take the risk. So the answer is stop retractive orthodontics. With that, I hope you enjoy the program that we have set up for you today, and I enjoy being with you.
Okay.
Ladies and gentlemen, I give you Dr. Bill Hang.
Well, thank you very much, Brian, and thank you to John Mew and Bill Mew and Mike Mew. It's a privilege to be part of this and doing something really I have a strong feelings and commitment to. In reality, I'm really not going to think of this presentation not as coming from my lips, but from the lips of 31 years worth of patients that I've been treating, working in the trenches, because it was 31 years ago this month that a woman convinced me to try to reopen her extraction spaces. She'd been suffering for more than half of her life with a headache pattern. I didn't know that it could be done, but I felt compelled to try to do it. It changed her life and got rid of her headache pattern, and in the process changed my life. Interestingly, I get patients from all over the world, all continents except Antarctica, contacting me. I've treated people from more than half the states in the United States and several foreign countries. Just today, I have people from Indianapolis, Indiana, and Portland, Oregon, just to let you know how prevalent it is. After doing this for many years, I came up with an idea that indeed we are dealing with a syndrome, and I believe it is a very real syndrome. It's ERRS, an acronym which means mistake, obviously. And I call it extraction, retraction, regret syndrome. And I've defined it as a constellation of aesthetic, functional, emotional signs and symptoms caused by tongue space airway reduction from orthodontic retraction, all of which are preventable. Because honestly, prevention is a choice. So it is the preventable syndrome. So what I'm going to offer you here today is really some ideas that come from 31 years of experience of doing this. But I want to, for dentists who are listening, I want to pique your interest, and for patients that are listening, ready to commit suicide because of the way I feel or the way I look or both. But let's first look at the science here and look at the literature, whether or not retraction can affect the growth of the face. And this is out of the American Journal of Orthodontics, a patient who is missing lateral incisor teeth, and you can see some primary teeth there. From the age of 8 to 12, the orthodontist here expanded the maxilla, which is great. And you see the upper incisors come downward and forward. And you see the lower jaw comes forward massively with normal growth, as we have been taught that it would. The next part in this treatment is the second phase of treatment, where they actually talk about bringing the cuspids forward into the space and substituting for the missing lateral incisors. A subject, by the way, that the Journal of Clinical Orthodontics had a seminar on just this last month, still talking about how it's okay to do this. Apparently, they don't look at this article here from the refereed literature, where you see after the spaces have been closed, the upper incisor has been retracted, and look and see what's happened to the growth of the lower jaw. The formerly forward-growing lower jaw is growing vertically completely. And in your mind, you can think, what does that do to the airway, given the fact that the genioglossus muscle in the entire tongue attaches to the lower jaw? In reality, I think it has a massive effect on the face, and this is not an isolated case at all. I'm going to go through a few cases here so patients can realize there is hope and see some similarities to their own case. They're going to go from very easy to do and to much more involved. But this is a 3-ring binder that I got from a woman in Chicopee, Massachusetts, which is almost 3,000 miles from where I live in California. There are all these sections that she'd been concerned about and things she had done over the 16 years. She was 30 years of age, 16 years since she'd finished her orthodontics, and was very unhappy. Here she is, and you can see her teeth. They're nicely aligned, straight, but she is not the least a bit happy with it. And I'll offer some of the words that you can read here that she says in this 3-ring binder. These are all taken directly from her. You can read them as well as I can. These are none of these are good. She's very unhappy, obviously. And she's ready to begin this journey. And she says here, and to regain my 4 bicuspid teeth, to finally see my real, individual, true, and natural face again that was totally destroyed. She talks about it being dehumanizing, hollowed out, demoralized, lost, disturbed, backwards, empty, constricted. You can see all these words. They're very negative, obviously. And this is not isolated. There are many other patients who've given me similar descriptions of what's been going on for them. And when we said we would finally agree to reopen her spaces for her, this is her direct quote from her to my treatment coordinator, to my wife, when we said we would do it. In her particular case, you can see that her airway was actually very good, and it was one of the least of her concerns, although it was a concern. Even with that large airway, people don't like their tongue space constricted. I'll just show you a little bit of the process here for those who've never seen it. We use removable appliance to start with, and those orthodontists and dentists who are looking probably are having a rather sympathetic nervous system reaction, seeing a massive open bite. On the other hand, the patient is literally thrilled with what's going on. And these are pictures that she sent me prior to her next visit. And this is what she says to me when she's ready to come back. She's extremely happy. She's experienced all this, my entire face, my mouth area, jaw, ears, and TMJs to continue to feel and look better and better. Overall, I also feel so much more balanced. Looking very forward to getting the braces on and going on. So here she is. We've placed braces, and you'll see for the orthodontists who are having a heart attack right now, seeing this massive open bite, you may think it will never close. Well, that's not an issue. I've been doing this for 31 years. And believe me, I had my heart attack when I started trying to do it originally because I was on new territory for me. So here we have it. The open bite was closed without any effort at all. It goes with the arch wires. For those of you who are concerned, we've also widened her arches dramatically with upper and lower expanders to get a wider circumference. You can see that she's had zirconium implants placed. You can also see here from the front a much broader smile that she's happy with. And for those of you who are concerned about recession, I don't believe it's a big issue. And I don't have them here, but I have 7 articles from the refereed literature discussing how you can dramatically advance teeth without causing recession. Those articles I'm happy to have available to anyone who wants them. Any 10-year-old child with internet access could probably find the same articles. So the important question here is, should she have had an informed consent about what the changes to her face would have been? You can decide whether you think that's appropriate or not. Or how about another girl like this one right here who has severe crowding for her upper lateral incisor teeth? And I'd like you to look at her face right here, maybe a little closer here. You see it. And so she started an extraction process, and this is then what she ended up looking like after she's an adult and her treatment has been done. Her smile is gummier and her face is caved in. Now you can look at her profile in this picture and see just how caved in it is. And you can think to yourself, would that have happened had she not had this retractive orthodontics done? You can also see that her lower incisors were crowded. And those of us who have orthodontic training, most of us were taught that extractions are necessary for stability. I happen to believe that there's less stability once you take out bicuspid teeth and do this kind of thing, because you make it impossible for them to have proper rest oral posture because the space for the tongue is limited. Here we have a singer, and she actually got her high range back, which is another of what I call the, oh, by the way, Dr. Heng comments that come along the way. This woman went into her treatment entirely for aesthetic reasons. And the day we took her braces off, she said, oh, by the way, my neck pain that I've had for 20 years is gone. Another, oh, by the way, Dr. Heng comment. And you can see here she's been restored, and she's got her nice new smile. But look at the smile before with the gumminess where the teeth had been pulled back, and now we've put them back out where they were meant to be. She's much happier with this. And you can see that her profile has been improved rather dramatically too. But I'd like you to note once you've done this, sometimes you can't get rid of it completely without going through surgery. So again, with her parents' journey for her, if they'd have known what was really going to happen to her, you decide. Here's a gentleman who presents with an open bite and severe crowding for the upper lateral incisors and some moderate crowding in the lower. Now, many orthodontists would look at him and say, oh, yes, we can make these teeth fit by taking out 4 bicuspids, and that's exactly what was done. I happen to call that making teeth fit on jaws that don't fit. I used to take out teeth all the time. As a matter of fact, more than 50% of my cases I took out teeth in. I stopped that about 1982. So I understand both sides of this from the way it's done and the thinking process behind it. I'd like to show you what he looks like. This is a little video thing where you can see him watch his face change after his orthodontics. There he is as an adolescent. Now watch one of my bioblock orthotropics patients' face change. Now watch his face change from the time he's an adolescent till he's in college. Now watch her face change from the time we finish her orthotropics till she goes off to college. And now we put the Bolton norms on their face, and you see that her face is nearly on the Bolton norm, and both of his jaws are massively recessed. And I believe the earlier the retraction happens in cases like this, the worse it is. But let's look at what really happened to him. Here he is. He's actually undergone orthodontics twice with the same orthodontist in this case. And you can see he has recession on the lower incisors. The papilla are gone. These teeth are in traumatic occlusion. He has posterior open bites. The second time he went into braces was to close the posterior open bite, and the orthodontist did what normally is done, put on vertical elastics, and the spaces came back because there was no room for the tongue, and lateral positioning of the tongue would produce the open bite. I would have loved to have opened his 4 spaces for him, but that's not going to happen in a case with a minimal overbite like this. And so we ended up saying this is an orthodontic surgery case. And he was so insistent, along with his family, of doing it, they were willing to pay for it if they had to. But you can see how dished in his face is and how long his face is. Here we have him ready for surgery. I won't go into that, but just to show you that it can be done. And here he is after the braces have been removed, and he's a happy man. He can breathe better. And his face went from here to here. You can see pre-treatment, his first orthodontics. Here he is after both orthodontic treatments prior to having treatment with us. After the surgery, we're able to take his face from the left slide to the right slide. But in reality, even with that, his lips are still back a little bit from where they might be. A nice change for him. But I would maintain if he'd never had the retraction in the first place, he'd have an even better profile. And if he'd done orthotropics, as John Mew has outlined it, his face height could have been reduced and his open bite could have been closed. We call that surgery without a scalpel. But unfortunately, he didn't have the opportunity to have that. So here he is prior to all orthodontics, and this is the best we could do after double jaw surgery many years later. A nicely improved profile from where he double jaw surgery to get there. Do you believe that his parents would have started this journey had they understood where he would end up? So we talk about the big issue here, and it's been kicked around in the profession for many years. But let's look at an exact case here. Here's a woman who has moderate sleep apnea and sleeps about 2 hours a night. The kind of person you don't want to meet very often because they're not very happy. But we opened up her spaces for her in the maxilla mainly, some in the mandible, and we were getting her ready for surgery, but in the process, she didn't want to do it. She went and had a sleep test done, and here's the result of that sleep test, saying that her sleep apnea is completely gone, despite the fact that she gained. But she never went ahead with the surgery because merely reopening the extraction space in the maxilla only got her rid of this sleep apnea. And realize that sleep apnea is an end-stage disease thing here. You don't even have to have sleep apnea to have real problems. Many people don't have sleep apnea and have upper airway resistance, or even some of those don't have upper airway resistance, but they just don't sleep or breathe well. So we don't want to focus all our energy on that. So I put this together several years ago and say, could you retract enough to cause sleep apnea. And I've used this in lectures starting at the University of the Pacific. And I've asked the audience, is there one person in the room who would disagree with this? Not one person ever in one of my lectures has disagreed. They all agree that you could retract enough to produce sleep apnea. Then the obvious question to me is, how far can you retract safely? Well, I'm not that smart. So I don't know. And morally retract at all. And I believe this right here is the crux of what we're talking about today. We're talking about something we've been doing for decades just because we've been doing it for decades and no one's ever done the look at what the literature says about it. And here you see an article from China that saying that it does reduce the airway. Here's another article from China saying that it does reduce the airway. There's a fourth article from one of the best known names in sleep, who's passed away a year ago, Christian Guilleminault at Stanford, talking about how the airway is reduced in extraction and when teeth are. And he talks about it. Here's further. Known to predispose to collapse of the upper airway during sleep and presented with OSA recognized at a later age. And another one here. This is from European literature, International Journal of Dentistry and Oral Science. This is another one that says, Florida. And it's interesting because it was a, quote, consensus conference. I have never seen anything approaching consensus in dentistry. I believe that's kind of almost as silly as thinking that we're going to have consensus on the presidential election in this country. I see no chance of that. But one of the speakers, here's an article that he cited of his own saying that there is no relationship between retraction and the reduction in airway, but none of the speakers cited any of the 5 articles which I just showed to you. Again, I think any 10-year-old child with access to the internet could find those articles. I'll let you decide what you think that means. So let's look at another patient who really has a even more involved situation. And just look at this little girl right here. And John Mew can look at this and know exactly what needs to happen. And those of us who do orthotropics know that her upper teeth need to be moved forward and her lower face needs to be forward. But instead, she gets fixed braces and she has teeth taken out. And here she is when she's done with that. Look at, she has straight teeth, a nice smile on her face, and a nice hairdo. I remember those hairdos. She's a happy girl. But happiness doesn't last forever. And here she is in her mid-40s. And these are the things that are going on. And yes, that is indeed her bite relationship. That's the way her teeth fit after all of this and many years of trying to find a solution. She's got a long medical history, fibromyalgia, and you can see all this, adrenal system collapse, neuropathy, you name it, she has it. And she has sleep apnea controlled with an appliance. She's had problems with her jaw joint. And from day one when I saw her, I told her she was a surgical case and she would require total joint replacement. And this was the sad thing that she said. We've spent so much money on me, I'm really not worth it. Maybe I should commit suicide. And that's truly sad. And if you had an airway that was as small as hers, maybe you'd be thinking that too. When people have these kinds of airways, and get rid of her sleep apnea and make it all go away, but it didn't. And so we ended up having to go to surgery, and this is after surgery. And you can see she's had a total joint replacement. You can't see it, but trust me that she has. And she's fine now after many years of suffering for more than half of her life. And she's ready to be restored. You can see her profile, which has been brought forward with the surgery. And you can see her smile in the beginning and the smile afterwards. And life is good for her now. You can see pre-treatment plus post-treatment for plus 2 years. She's prospering and doing quite well now. You can see her airway was dramatically improved with the surgery, which is a lovely thing. And you can see, do you think she should have been told that possibly this would happen? And there's a mechanism why the joint degenerates with these cases. I can't go through it here today, but we can easily go through it in our lectures, and we do all the time. Again, would her parents have started the journey had they known this was where it was headed? And she has a nice life now. I see her on Facebook all the time, and life goes on. She's living a great life now. Finally, we have one final case here from a gentleman from New Jersey. And here he is. That showed all of his pictures of what he looked like, and he'd had orthodontics done. And here he has the treatment done at age 14, finished at age 16. And that's what he looks like when he comes to see me. He had clicking in the jaw joints, as many do. Again, I can't go through why that happens, but it happens very frequently. He has an anterior open bite, and all this was taken care of and with some surgery, but he was going downhill like crazy. He's had other surgeries done and long history of back problems, and he really does qualify as what I call a train wreck. When he came, he couldn't even sit down in our new patient room. He was pacing around because he was in such pain. It was a struggle for him to fly from New Jersey to Los Angeles just to get to see us. Sitting in an airplane was not okay for him, and he readily admitted that he was a suicide risk. He says, "I'm going to commit suicide if you can't help me." We can't promise him anything. We couldn't dare promise him a resolution of even one symptom. Here he emails me a few days, about a month before his proposed surgery, on a Sunday night at 12:40 p.m. in the East. It was 9:40 on the West Coast. And he's ready to pay me, fly me to New Jersey, pay me $25,000 to make the final adjustments for him. I would say those are the words of a pretty desperate individual. I read that and couldn't believe it and didn't answer him. The next morning, I woke up to this email. And here he's suggesting that was kind of nutty. Maybe he could find someone to drive. He could sit in the back seat of a car and have someone drive him to California for me to make the last adjustment. I emailed him back and told him, just have the surgery done. We'll fix the teeth later. So here he is. And he went to have the surgery done in St. Louis. He's now pain-free. These are the pictures on the right hand from the surgeon. Here he is in my office about 6 weeks later. He's had the total joint replacement done. Here he is, a gentleman aged 28, and he's got an artificial jaw joint because there was no way to resolve it and keep the jaw joint. It was severe degenerative joint disease. And this is a quote from him. He weighs 117 pounds after the surgery. He weighed about 120 before the surgery. We referred him for myofunctional therapy. Here he was when he was 19. At 170 pounds, bodybuilder with a beautiful body, in great shape, but the last 9 years of his life was a downhill spin in his mind, all because of this. And here he is 2 months later. He's gained 20 pounds, eating 6 eggs for breakfast. I'd like to do that, but I'd weigh 400 pounds if I did. And he finishes the case. He's very happy, and he's decided that he wants to become a dentist because he doesn't want to see one more person ever treated in the way he was, and he wants to be able to help people who have had it done. You can see what a great job the surgeon did in bringing his face forward, and his airway is open, and he's a totally happy guy because of it. You can see a nice smile. We did not reopen spaces for him, but that's a long story. But he owes his life to Mike Mew, really, because he'd seen his Facebook group, and that's how he got my name. And he was in shambles, it says. Every day was basically the equivalent of human torture. And he talks about the surgery here and how it changed his whole life, etc. So you can see that, rather dramatic. You've gone from, gee, I don't like the way my face looks, to, gee, I'm ready to commit suicide. And I don't want you to believe that more than you would like to think. And I get these people from all over the place. He wants to be a future dentist, and he's pursuing that, as a matter of fact. So how would you have predicted when he's in first grade that this little boy at So thank you so much for all of you who are on here, the dentists, orthodontists, and for the patients. I hope that I've given you some things to think about.
Thank you,
I think
Bill.
I'll finish here. And thank you again, Bill, John, and Mike for the opportunity to put this together. And I look forward to hearing from.
Thank you, Bill Hang, for an amazing presentation. That was an overview that gave you guys a view of several patients with a lot of similarities with extraction, retraction, regret syndrome. For my presentation, what I'm going to do is give you a deeper dive into one patient's story. So bear with her, stick with her story here. It's 16 minutes, and I think you're going to learn a lot about what the implications are about whether we should ever extract and retract. So Bill, if you want to make that full screen and start the video over, that'd be great. No sound, Bill. Go ahead, Bill, and start it over and turn on the sound. It looks like we still have no sound.
The rest of it.
No sound troubles, Bill.
What it looks like to me. I didn't want to have a mandibular advancement. So it just seems the appropriate thing to do to have
Bill, you're going to have to start it over. It looks like there's a problem with that.
Okay.
If you want me to try playing it from my desktop, I could.
Okay, hold on.
Can you see okay, Bill? All right, here we go.
Start from the beginning. Well, it all started when I was a 35 years old. I needed to replace 4 veneers with 4 teeth. And he had convinced me, he said, "Well, you need orthodontic treatment." So I got the evaluation by an orthodontist. Okay, you have a couple.
What's happening?
We can either remove 2 from the top, push them back so that they all line up with the bottom. Jaw surgery to advance your mandibular and bring that out, and then we need to do. Then I said, "My God, years, and now it's like ortho." He said, "Well, that's kind of what it looks like to me."
Someone needs to mute their sound. Everybody mute, please.
Very invasive. So it just seemed the appropriate thing to do to help the 2 bicuspids removed from the top, and then the pushed back. And you know, I never knew what the ramifications were. I never knew that there was going to be any kind of a problem. I just, at that point, I just figured 2 teeth are going to be pulled out, and the rest of them will be advanced back. Not advanced back, but pushed back. So I went ahead with that. So I was approximately 45 years old at the time. I had the teeth pulled out. Then as when the sockets healed, I went in to the orthodontist. He started the procedure by putting the braces on. Okay. And that closed the gaps. So as that was happening, about a year into it, I started having like choking dreams. choking. I would choke. Like one night I felt like I dreamt that somebody's hands were wrapped around my neck. And I would wake up like that. I would wake up quickly and I'd remember that choking feeling. And then other times it was just like, just constant awakening. And so by the time I got the braces off, I was 47 years old. It was 1999. And shortly after, I was, say, about a month, I started waking up. I still had the choking things. It wouldn't happen all the time, just, infrequently, but enough to make a difference in the sleep. So I started waking up gasping for air this time. I'd jump out of bed and I would go, like as if, when you come out of water, like that. So I jump up and I would just gasp and I would, try to get my bearings and so I went to my doctor. I had, by this time I had moved into a new home, had a new doctor, and she said, well, maybe you have nighttime anxiety. And I said, well, I know I have some anxiety sometimes, life brings you that, but waking up in the middle when I've gone to sleep, I just don't understand how that would be anxiety. She says, well, it happens. So, I go on with my life and, you're trusting the dentist, you're trusting the doctors. And I was going to a fabulous doctor, one of the best places. By the time I got the braces off, I was 47, 48, 49. I started getting supraventricular tachycardia. And I wound up in the emergency room a couple of times from work. They'd rush me to the hospital, and the doctor would say, SVT. And that was in 2001, the SVT. By 2002, I was really, really, really feeling sick, very sick. And my hair started coming out in clumps. Within 3 months, my hair was completely gone. And then within 3 months after that, my eyelashes fell out, and little by little, all my body hair was gone. And I just felt sick, shaky, weak. And I went to the emergency room. They took a blood test and everything. And she said, then she ran some more tests and stuff. She says, oh, you have diabetes. And things were okay, but I was still waking up, gasping. We're fast forwarding to 2006. And I woke up one day and I got out of bed and I thought I was going to collapse. And my heart was just going in different directions. I called my daughter and I said, can you get me to the emergency room? I was getting ready for work, but I didn't think I would make it. Turns out I'm at an AFib, atrial fibrillation. The doctor kept me there overnight in the hospital. And he said, what? I said, I don't know. I don't know where this stuff is coming from. I'm having a suspicion that it could be from the orthodontic treatment I had. There's some correlation. All these problems are happening to me. As I Googled all my problems, it finally came up, sleep apnea. So I went to my doctor and I said, I need a sleep test because I feel that I have sleep apnea. With all these problems I've developed in the last 5 years, I need to get a sleep test. She says, okay, I'll send you to one. So she gave me the referral. I took the sleep test in San Francisco at St. Mary's, and they confirmed it was sleep apnea. The diagnosis was mild sleep apnea / upper airway resistance syndrome. They recommended CPAP, and I started it. And it did help. It was a lifesaver. So I used that from 2006 on. But after a while, as a CPAP user, you start pulling it off. And, there's nights where when you do pull it off, then you start the gasping. And it's a Band-Aid. It's a Band-Aid therapy. All the problems I developed happened within the first year of orthodontics. It was like this whole downhill spiral. And so I said, it has to be this. The only problems I ever had in my life were asthma and allergies up until my orthodontic treatment. So once I found out I had the sleep apnea, I started researching on the internet reversal of orthodontal treatment. And there was nothing at the time. We're talking 2006. There was nothing. I remember going to my dentist and I asked him, you know, what do you think about, could I ever get this reversed? I mean, is it possible to do something like that? And he says, oh, I've never heard of that. And he referred me to his periodontist, and he said, no, I wouldn't recommend that. And so I just kind of continued on with life, thinking that because there is nothing on the internet, there is nothing available. And so I continued on with my life. I mean, what else is there to do? But just try to keep myself as healthy as possible. So I started researching again how to open up the base of tongue, because I was told by a ENT, did you know you have a large tongue? And I said, I do. And she says, yes, you have a very large tongue. And I said, and I started thinking to myself, well, why didn't that orthodontist see it years ago? If he knew I had a large tongue, why would he be pushing my teeth back? So I started researching base of tongue, how to get it open. So I found a doctor, and he was a fabulous doctor. He did base of tongue radio frequency, where it shrinks. They put in literally a prong. It goes in the back to the base of the tongue and fries it. A couple of areas so the base of tongue will shrink. So it seemed to work for about 6 months. And then I went back to him. I said, I don't know if this is wearing off. He says, we can do another procedure. And I said, do you think this is safe? Is it okay? He said, yeah, it's safe. It's okay. So we did another procedure a year later. And then the same thing 6 months later, it just didn't work. So I'm still researching reversing orthodontics, and I don't come up with anything. And they finally started having something on the internet come up about it. I spent a lot of time gathering the information. I was, using the CPAP, and then one night, it happened to be New Year's Eve of 2013. I forgot to put my mask on. I don't know, sometimes that happens. And I woke up gasping for air, but it was so bad this time, and my heart was going in the different directions. And I said to myself, it was about the worst it had gotten. And I said, if you don't do something about this now, you're going to die. And so I got up in the middle of the night. It was New Year's. And I started Googling again. And so I found a couple of doctors, dentists, people who could do reversals. So I set up some appointments for consultations. And it wasn't until I had Dr. Hockel was on the list of the consults. So I called him up. I came in and I asked him, can you do this? The other consults, I had all negative responses. Some didn't want to touch it. Maybe they thought it was going to be a lawsuit. Some just thought, oh no, how old are you? And I have aged. I mean, unfortunately it's taken this long to do this, but I'm so glad. The day I walked into Dr. Hockel's office was like a miracle for me. And I sat with him. I cried. Excuse me. When he told me he could do it, and that he thinks that he was able to do this for me. And I asked him, okay, so I gave him a lot of questions. What do I do? What are we going to be doing? How are we going to be doing it? I ran the gamut. And so we began the procedure. And as if things were going along, we put the sagittal and this and that. He's such a patient dentist, doctor. And as the spaces were opening, I said, this is truly a miracle that I'm able to do this. And then we put the braces. He filled in the gaps because he put the sagittal, opens up the spaces. And we filled in the gaps on the bottom teeth. The implants went in where my teeth were removed, and I'm back to normal now. My sleep apnea is gone. I just took my sleep test at Kaiser about, I don't know, was it 6 to 8 months ago? And sleep apnea is gone. It's gone. I almost fell off my chair when he told me. The atrial fib, I haven't had that in about 1.5 to 2 years. That's gone. My sleep is beautiful. My dreams are back. That's one of the things that I noticed in the beginning is that I stopped dreaming. It happened about a year after the braces were on and pushing the teeth were in the movement back. I stopped dreaming. And now I dream. It's been about 1.5 years at least. And I gave Dr. Hockel the latest sleep apnea test that I had at Kaiser. He was thrilled. Because this is what his mission is to help people like me. And I just feel blessed to have found him. I really do. I would suggest to anybody who has sleep apnea, who have had any kind of orthodontic treatment in the past, to perhaps check out a dentist, orthodontist, somebody in the field of being able to restore your teeth to the way they were. And see, because I have to say that not all sleep apnea comes from this. You know, there are various reasons. But if you're a person that have had bicuspid removal on the top or the bottom, I would and you've noticed any kind of sleep or weight problems or any heart problems or things that come on because of it, check it out. Check it out and see what you can do to help yourself in that area. Going through this procedure, it is difficult. I mean, as far as all the appointments, the unknown, if is this going to work? I mean, you need to have some time to do this. Also, it's not painful. It's not painful at all. So if somebody's saying it can't be done, for all the problems that develop, I would check it out. And I'm glad I got it done because the outcome is this. My teeth are back. My health is back as far as it can possibly be back. And I'm just glad I jumped in and found Dr. Hockel. I'm so happy I did.
We're ready to move to another patient perspective from Ireland.
Hi, my name is Ireland. I am 21 years old. I'd first like to thank the organizers of this event for asking me to share my perspective on this subject. I had extraction retraction orthodontics when I was a kid, and I have been suffering the consequences ever since. So, share a slide here. It all began for me back in 2007 when my parents took me to the recommended age 7 orthodontic checkup. Here are the pictures from that first appointment. If Bill, are my slides going? Okay, I can't tell. I can't see the screen. So here are the pictures from that first appointment. I was a normal looking kid, nothing especially unusual about my face. I was diagnosed with crowding and a deep bite. My orthodontist told my parents that my mouth was just too small to fit all of my teeth and that they would have no choice but to extract 4 of my premolars. So I got those premolars extracted when I was 10, and then I got braces at age 13 to close the gaps. Almost immediately after getting these braces, I started noticing this intense tension all through my face, neck, and shoulders. I could no longer bite together comfortably, and my lower jaw felt like it was being trapped backwards. I was really confused. I had no clue what was going on. So if we fast forward to 2 years in braces, I was 15 in these pictures. I was not especially pleased with my face. My jawline was now rounded instead of the nice curved definition that I had my entire life up until that point. I felt so ridiculously tense. I could hardly even stand up straight. It was painful for me to smile. My jaw joints were clicking. I could no longer close my lips together without serious mentalis strain. And I told my orthodontist that I was uncomfortable. I told him that I did not like what was happening, but he told me that it was all in my head and that I would get over it eventually. But I never did, because these problems, they never went away. In fact, they only got worse. My jaw joints are deteriorating. I can hardly go more than like 10 minutes without using cough drops or drinking tea because my neck muscles are so tense that it's physically difficult to speak. I started physical therapy when it was right after I started high school. And despite only being a teenager at the time, they told me that I was one of the most tense patients that they had. I've been on a leave of absence from college for almost 3 years now because my symptoms were so bad, and honestly, I was really depressed. The past years have consisted of countless appliances and expanders, myofunctional therapy. This is my 4th set of braces. All of this combined has cost $30,000 plus, all in a desperate attempt to try to alleviate my symptoms. But the damage has already been done. And to think that this could have been prevented, to think that this was the result of an optional aesthetic procedure, and that my parents paid to have this done to me. They were never given any other options, and they were never warned of the potential side effects of this procedure. Side effects that have been reported in medical journals for decades before I ever stepped into an orthodontist's office. If my parents had been informed of the side effects, these consequences would never have happened in the first place because my parents would never have consented for me to get this treatment done. So that is a very brief overview of my personal experience with retractive orthodontics. But if we're going to be real here, my story on its own doesn't really matter that much because it's just an anecdote. If it's just me sitting here telling you about what went wrong in my orthodontic treatment, who knows? Maybe you're thinking that my orthodontist was uniquely bad at his job, or maybe I had a particularly complex case, and that is a possibility. But the reality is, it's not just me. There have been hundreds, if not thousands, of patients over the course of decades publicly reporting the same oddly specific side effects from the same specific orthodontic treatments. And that is significant. That is something that, at the very least, deserves a legitimate investigation. Here are some more patient pictures that I've collected from talking to patients to help illustrate this problem. You see, the facial damage that occurred in my own case is the same pattern of facial damage that occurs in every individual that has extraction, retraction, orthodontic treatment, just with differing levels of severity. And it's important to be able to recognize this pattern, namely the flattening of the midface, dished in mouth region, lengthening and narrowing of the face, and jaw and neck muscle tension. These are aesthetically disappointing changes, but they also have serious health consequences that negatively affect young people's lives and futures, their ability to pursue their dreams. The typical pattern of health problems includes damage to the jaw joints, breathing disorders, acute or even chronic jaw pain, inability to chew and speak. These symptoms are truly life-destroying. Now, I'll just be really honest with you here. If I hadn't personally experienced the negative effects of retractive orthodontics, I probably wouldn't even immediately believe the claims that are being made. Because, for one, the symptoms associated with extraction retraction orthodontics are difficult to explain. Feeling like your jaw is trapped, which was personally my most frustrating symptom, that's something that's not necessarily relatable to people who haven't personally experienced it themselves. And I don't blame anyone for that. It's just the reality of the situation. But it's part of the reason why people are not especially inclined to believe stories like mine immediately, and stories like the thousands of patients out there like me. Also, many people talk about the damage caused by retractive orthodontics, but there are hardly any pictures or x-rays on the internet that actually show and explain the damage that's done. People need to actually see the damage that's caused by these kinds of treatments in order to believe it. And they need to see the damage in many different cases so that it becomes clear that this isn't just an anomaly that happens to a few unfortunate people, but rather this is a standard result of extraction retraction orthodontics. So to address the lack of physical evidence for the claim that retractive orthodontics causes damage, I'm working on an archive of patient stories and pictures from before and after orthodontic treatment. It's called the Retractive Orthodontics Archive, and I have a slide to show that if you want to bring that back up. I don't know if it's back up, but you can find the information for this through my website, The Jaw Project. It's just thejawproject.com. I created this website a year ago to raise awareness of the consequences of retractive orthodontics so that other people don't end up like me. So this archive that I'm creating is industry independent. It's run by myself and purposely so. My goal here is to give patients like myself a voice and help these issues be taken seriously, not only so that we, the patients, can get the help that we need, but also to help prevent any more children and even adults from having their lives damaged by these treatments. So if you are a patient out there and have experienced negative side effects following retractive orthodontic treatments, please consider sharing your story and your pictures. It's through sharing this kind of physical photo and x-ray evidence that this problem will finally be acknowledged and taken seriously. It's fantastic to have the backing of so many professionals out there, but we also need the physical evidence from many people in order to get anywhere. So please, if you are willing, if you are comfortable stepping forward, please consider contributing to the archive. It's vitally important for the health and well-being of so many people around the world for these issues to be taken seriously so that extraction and retractive orthodontics can be put to an end once and for all. So thank you again for including me in this panel, and I'm looking forward to seeing where this discussion goes.
Thank you, Ireland. Great presentation.
Well
That was
done.
really good.
Thank you.
So we now have about 15 minutes for a panel discussion on this. And Bill, I don't know if you want to put up any questions or that have come up. Here we go. JFM asks, I have a mucosal tongue tie and I went to Dr. Barrios, an orthotropist. He said I have a flat cheekbone because I'm a mouth breather, but I've always been a nose breather. And there's not really a question there. So maybe let's take the next one. Unless anyone wants to comment on the connection between tongue ties and facial development.
That's a 2-day seminar there, Brian. Growth and development, right? The functional matrix hypothesis. Our tongue is what helps develop our face. If it's tied down, you're gonna have aberrant growth and development. I'll just comment that you only know what you know. So when I hear a patient that says that unless it could be measured, it's what they feel. I'm not going to say they're wrong, but maybe there is more mouth breathing than he thought.
Here's another question. What do you think about retractive orthodontics in preparation for surgery? I'm class 3, braces at age 10 to 14, no extractions. Now at age 21, my ortho wants to remove 2 upper teeth to decompensate in preparation for her surgery. Bill, your sound is not on. For some reason, we can see you talking but not hear you.
Brian, are you hearing me?
Okay,
Yes.
Now we are, Bill. Go ahead.
Okay. Way back, Brian.
Your connection's still really bad, Bill. You're going to have to start over again. I'm sorry.
Doing orthodontic surgery cases, 48.
So there's a lot of work in this question. I answer?
Yeah, go ahead, Barry. Sorry.
So if that your pictures, and but I can imagine that one of the situation growth oriented lack of development of upper jaw, and when one is trying to straighten in concept of jaw match, and then they so in case that may lead upper teeth forward the lower that they're stable, bringing them over may make them more stable than bringing forward to address that problem. I don't have enough information, but if you're going to move jaws forward, then be a decent treatment plan for you. But if they're going to be moving jaws back, then that is not.
Bill, hang. I don't know if you have a better connection now. We lost you in your first attempt.
Can you hear me now?
Yeah.
Okay. Years ago, my I'll use the word never because I don't think I would ever see the reason. If there are compensations that need to be taken care of with proper surgery in class 3 cases, most of the time you're actually wanting to advance the maxilla, and believe it or not, you're wanting to advance the mandible. That's one of the biggest misconceptions in orthodontics, is that the mandible is too far forward. It is in some cases, but it's rare. So if you're going to do orthodontic surgery to resolve a class 3 relationship, most of the time you're going to advance the maxilla and the mandible. And in the process of advancing the maxilla, the angulation of the upper anterior teeth can easily be taken care of by the surgeon, which optimizes facial balance and optimizes tongue space. And that's a big, huge thing. I've recently done a surgery case in the last year and a half where someone was going to have the mandible set back in a class 3 case. We did the exact thing I just described, and the woman is beyond ecstatic with her result, both aesthetically and functionally.
There was a question on here just a second ago about what about expansion after orthodontic surgery? Is that an option? I think we'd all agree it is.
It is, and there's a lot more than has to, the big question that has to be answered here is why did the orthodontic surgery fail? And so frequently,
well, we lost Bill again.
all right, improper preparation, or a surgeon who really doesn't know how to optimize facial balance and make the teeth, they're usually focusing on making teeth fit and not on optimizing facial balance, optimizing airway, and optimizing TMJ health. The three things that.
So the answer is check out what the reasons were for the failed surgery in the first place, but expansion alone can be done, but it may not be really the whole answer. Next question is it possible to reverse retractive orthodontics? In my case, I had 2 upper premolars removed to fix an overbite. And if you've been watching, I think the definite answer by everyone on this group is going to be yes, it's possible. Anyone want to comment?
Well, your video examines a decent point. And, as an honest, I will say that orthodontic doesn't cause an etiology problem when you work a teeth. Jaws match that was partially there, but orthodontic doing is straightening the ignoring problem.
It keeps cutting out, Barry. For some reason, we're not getting everything there.
So Brian, can you hear me okay? Am I buffering as well?
Yeah, Mark, I can hear you.
Okay. I'll just comment that, we're just to clarify, and I know everyone on the panel understands this, but maybe the audience doesn't necessarily, or they might, but we tend to be focusing just on structure. And it's not just about creating more ton space, because we also have to deal with what caused the problem to begin with, which is aberrant growth from the very, very beginning. And so function has to be addressed and repatterned as well. And then the third thing that we seldomly talk about is the behavior. When I'm talking about behavior, I'm talking about breathing behavior. Breathing is a behavior, not to be confused with respiration. And that also needs to be repatterned, because that creates a lot of the autonomic nervous system problems. So I know it's a big discussion, but we're focusing on structure, but we need to actually focus on structure, function, and behavior. So it's not just a matter of doing a surgery and doing it right, but it's also dealing with these other issues.
Yep.
Thank you.
Can you hear me, Brian?
Yes, Ben.
Am I clear? I mean,
Yep.
I would agree with everybody. When you ask why did the surgery fail, in most instances, they're not taught anything before about function, and they're not taught anything after, and they maintain their function afterwards, and things just collapse back to where they came from because nothing has changed. That has to change. There needs to be an oral myology program before and after the surgery if they hope to expect to have any kind of stability.
No question.
Mm-hmm.
Thank you. Next question is, my jaw pops on one side every time I open my mouth. No pain. Should I be concerned?
You need a diagnosis. That's just a sign, a standalone sign. Maybe, maybe not. Let's get more data. Let's not just jump at something. Something may be happening, but oftentimes it's not just as simple as, addressing one sign.
Next, Bill, were you going to say something?
Yeah, I'm happy to answer this question from a 27-year-old. There's always something that can be done. You're asking, can the spaces be reopened? The answer is possibly. That may be an appropriate treatment plan. And certainly at age 27, it's not a problem. I've done it for people in their 60s. But you have to do the proper diagnostics to know that it's the right thing to do. It may or may not be the right thing to do. And so I can't answer it definitively without a lot more information. I think everyone would agree with that.
Next question is, I'm 18 years old. I had braces at 15 to 16 and a half. So will mewing still work for me? I'm really depressed. Any experts on the panel on mewing to answer that?
hear me, bro?
Who?
No.
Can you hear me?
So I think I could hear someone. Yeah, was that you, Barry?
No, I was just going to say is maybe, but again, you know, a lot of callers that have questions are asking questions that you can only give very vague answers to because we need more information. It's not so simple as just saying, you know, this is going to work. Let's get more information. And again, let's not focus on structure.
But maybe just know that there are answers out there and keep your search going.
Yes.
Next question, Bill. I have a straight profile, no ortho, and perfect teeth and dental arch, and I'm going to have enough space for my third molars. Why are my cheekbones flat then? I'm 14 years old.
I mean, it could be a
Hey.
right?
I might address that a little bit. One of the things that Derek Mahoney said last year in a little Facebook thing was he'd only seen, now he might correct me, he'd only seen 5 maxillas far enough forward in his career. Now I thought that was a bit far-fetched, but it could be completely true. And without bringing that maxilla forward, you're going to have flat cheeks, and you're not going to have the nice cheekbones that you should have.
Yeah, there's good evidence. If you, one of the things that Barry and I talk about quite a bit is the anthropologic standard, a Paleolithic face. If you look at our faces 500 years ago, 800 years ago, that wasn't that long ago. They look very different from what we're seeing now. And the fact that you're that astute to even see that you have a flat cheekbone says a lot.
I think
so many people have the flatter cheekbone. We just take it as normal. We don't even think of it as anything wrong. And the fact that you have room for all of your teeth, I do too, on a profile that's also very far back. But the thing is, whether the teeth fit is not the whole question. We can have both jaws very far back and still fitting all the teeth in and still be in the completely wrong place. So any other questions, Bill? All right, we're on our own. Anyone else have a comment?
Well, I'm like you, Brian. I have room for all my teeth, but my father put on retractive headgear, and I'm only sleep apneic 70 times an hour on my back. So, and I don't really have an airway unless I bring my jaw forward, which what snore appliances do. I still, at 73 years of age, would consider having things brought forward. I really would. I know that it affects me badly, and so does my wife.
Brian, I'll just make a closing comment. I'll say we've been focusing, I mean, the audience by and large has been focusing on teeth. And I'm going to tell you that what we're talking about is not a tooth problem. That's just incidental. The teeth are just part of a functional matrix, a very small part, probably the least important part of this of our entire craniofacial growth. So yes, you can have enough room for the teeth, but that's only really a very small factor.
That's a good context, Mark, to put it in for a debate that's about, can extraction and retraction be harmful? And should we stop that? It's one question, but it's really a micro question in the bigger picture, and because it's really, again, focusing on teeth.
No question.
Yeah. It is, and it's one thing that I tell my patients, and I tell a lot of students that I've worked with, that it's not about teeth. I don't look at the teeth. If we get what we need for the maxilla and the forward growth and the widening, the teeth line themselves up nicely for us. We don't have to do all that hard work. And I think Bill and Brian, and I hope you guys all agree with that. It's amazing what you get without having a lot of stuff. It's amazing what you don't get if you don't have that. If you don't have that forward growth.
I think I remember hearing something about how straight all the chairs were lined up on the top deck of the Titanic at one point in time. Who cares?
Yeah, who cares?
Okay, Mark and Barry, it's time for the two of you, ladies and gentlemen, Mark Cruz and Barry Rayfield.
Thank you. Barry, you gonna pull up the presentation?
The presentation's up, and
I really don't see it.
On your slides.
okay, so, can you hear me speak?
Yeah,
I see that.
Or can you hear me?
we can hear you.
Okay.
Okay, good.
Okay. Here we
All right, go ahead.
So I'll just introduce my teaching partner and friend, orthodontist Barry Rayfield from the East Coast. I'm from the West Coast, and we work quite a bit together, and talking about this topic. And so what we'd like to do is we'll just kind of do a little bit of a tag team and share our perspective to support everything that the previous panelists talked about, and maybe from a slightly different point of view that hopefully we can integrate. So if we go on to the next slide, I'd like to share this. I don't see it, Barry. Can you put it on the next slide, please?
Yeah, the next slide is on.
Okay, there it is. So a couple of years ago, Barry and I wrote this this article to kind of make a point of the medical indication for why we treat teeth. And there's this orthodontist that previously had made a statement. His name is Joseph Gaffari, and he goes on to say how the time has come to forego this distinction between medicine and dentistry, as it's becoming harder and harder to pay attention to the teeth without consideration for whom to the person to whom the teeth are attached. And I think that's really, really important to step back and be a little bit more global, where we're actually treating a whole organism and the teeth are just part of a very complex system. If we go on to the next slide, Sachin Jain is a professor of medicine at Stanford, also talks about it, that we're in this moment where medicine and dentistry can better integrate knowledge to better serve the patients. He goes on to say how medical doctors and dental doctors should stop living in their own silos anymore. We're in a disease management healthcare system that tends to be hyper specialized and puts us in these silos that has very little integration. We're chasing signs and symptoms. We're learning more and more about less and less because of the specialty mindset, to where we really have lost our way. And yet, when you really understand the importance of the craniofacial complex and its natural development and the overall health of the individual, it becomes obvious that dentistry plays a much bigger role in global health beyond the non-integrated delivery of services pertaining to teeth, gums, and joints. After all, what other discipline in healthcare knows more about the craniofacial structures collectively than dentistry? Barry?
So also live a time when dentistry became involved in sleep med for the part, and for the part, dentistry is a role to put this fairly policy statement by the dental association reverses that. Really, for things like apnea, it's a problem for medical diagnosis and needed, and then dentists can play their in a pressure moment. They also included a statement of children that I think serve a working model for us. They say that in children, screening through history, clinical examination, identify symptoms, deficient and develop. And I think I agree that really accurate, and other risk factors that may lead to airway issues. The risk for sleep breathing disease is determined through dental referral evidence-based, appropriate treat isolated breathing disorders or develop, and the most important part, physiologic airway breathing pattern. Let's talk about what part the piece means. Airway and breathing basically has three components. One, structure. Two, function. And three, one seems to be missed more than any other, and that's behavior. And by structure, talking about the shape of the, so that it can hide an adequate size shape of the, from the tip of the nose to the bottom of the, there's no obstruction, so that there are no narrowings that create turbulence, air through easily. By we're talking about the stability of those tissues between the nose and the throat, so that they don't collapse. Anything that creates swelling, irritation, inflammation, things that that tend to tissue soft, make flap, make the air, and lead to lead more easily to collapse. Anything that helps boost the stability and resilience of the airway is helpful. And finally, the behavior Mark mentioned is because we need a balanced intake and delivery of oxygen. It just because breathing doesn't necessarily that we're getting oxygen where it needs to be. In fact, we know that poor modes of breathing can bring in plenty of air, but not deliver oxygen to the target tissues. And because oxygen is the most important nutrient for our bodies, it at a minute of existence in every system that we have, the way we bring oxygen in is critical. So we want to be able to use nose, because that's where we're supposed to breathe. We want to do it at a proper and volume. We want to power the lungs so the air is brought in efficiently. And we want to maintain a certain level of carbon dioxide to balance the oxygen that can jump onto hemoglobin properly, off of hemoglobin properly. Now, talking about the structure, I had to come into our office. Well, I think pressed the wrong button there. I had toys come into my office recently, and they were so diametrically different that I thought it would be a good way to introduce this issue of structure to people. This boy, 7 years old, is the son of a naturopathic doctor who very much of good feeding, good chewing, good tongue posture, breastfeeding, natural feeding, whole foods throughout the child's life. And she brought him in because, as she said, his upper front teeth were funky. When I looked at his arch, looking at especially upper teeth on that left picture, I saw an arch form and a palate that was wide and broad. The next day, I had a 6-year-old boy come to see me, and he had very different look and appearance. His parents came in because he had breathing problems and sleep problems. He was peeing in bed at night. He was grinding his teeth. A good night's sleep. And I look at the structure of his face and see the lower jaw significantly recessed, his mouth open. Especially when I look at that indentation in the palate, kind of someone's their thumb and all of that particular configuration there is a deformation. It is a deformity of the jaw, but I think that's every dentist should be looking for, matter what dental structure. Most interesting when you compare those two patterns, you can see how broad and bowl shaped, and is actually collapsed, and it's collapsed in dimension space. I know some orthodontists are keen to look at this and call it a narrow palate, and they'll use expanders, which will tend to widen the jaw, which is all well and good. Important to visualize this as a whole. The change in the maxilla in function are leading to structural changes all through that bone. And if we compare their cone x-rays, you can see immediately how the deficiency in the maxilla with the boy on the left is dramatic compared to the boy with the wide palate. Just look at all the surrounding teeth. Look at how look at the width of the jaw. Look at the width of the nasal aperture, because the maxilla includes not just the portion of the teeth, all to the bottom of the eyes, and it's backward. It connects with bones, skull, and in the maxilla like this. This is again a functionality and an anatomical deformity that we need to address.
You have the slide up?
The human airway slide.
Yeah, I don't see it. Okay, so let me just step back away from teeth, as we've been saying, and talk about the airway. It's, the pharynx. Actually, it's from the tip of the nose down to the bottom of the vocal cords, about 25 centimeters. It's what's called a functional space. It's not an organ, but it's defined by everything around it. So everything around it, in turn, is also dependent on its configuration and its geometry. Let's remember, if you can, what Don Enloe, as the acknowledged father of craniofacial growth and development, said a long time ago: the airway, in a true sense, is the keystone for the face. And what does that mean? That means that that keystone, if it's of the proper shape and size, stabilizes the entire arch, everything that's around it. So Barry, maybe you could do the slide change. And so think of it that way, that we have to really respect and not encumber the pharynx. I'm not seeing the slide change, Barry. I think we're kind of lagging here. So, well, Barry, can you go back to that slide, please? So Matthew Naughton, if you can go back to the airway slide, please.
Can you not see the slide?
I cannot.
Will you
go to the slide of the airway?
There you go.
And because one of the things I want to actually bring attention to is Matthew Naughton, who's a sleep physician, who said in the Blue Journal, the very respected Blue Journal, which is the official journal of the American Thoracic Society, is that there's considerable evidence to suggest that the bony structure surrounding the collapsible upper airway is responsible for much of the variance of percentage of stable sleep. Another way of saying it is that if you have anything that impinges on it, that collapses in on it, you're going to increase your risk for sleep disordered breathing. If we go on to the next slide, I don't know that this is working very well, Barry. I can't see any of the slides.
If you can use your tab key to the window that you're looking at.
I don't see it. Are you looking at the slide by Dr. Naughton where he goes on to say how short maxillomandibular length,
Yep.
caudally placed hyoid bone, that means it goes further back. The retrognathia and a long face have been shown to explain up to half of the variance of the apnea-hypopnea index. So this is coming from our medical counterparts talking about how the structure can affect the function of the pharynx. If we go on to the next slide, there is another reference here that says that there are evident and early that there's evidence that there are evident and early changes in facial growth and development among children with obstructive sleep apnea, and it's characterized by increased total inferior anterior heights of the face. And so I think it's very important to understand how craniofacial growth and development is the key. By the time the patient gets to the orthodontist, any change that perpetuates or exacerbates the problem, because now you've pushed the patient beyond their adaptive capacity, becomes a big problem. And this last little reference before Barry goes on to his presentation is really looking at several studies associated with mouth breathing and reduced growth as a result of reduced release of growth hormone. And this systematic review that came out of Europe a couple of years ago, looking at 247 papers, they distilled it down to 20, and they concluded that mouth breathing by itself should be considered a cause for growth retardation. And if you really understand the reason why, it makes sense, because peak growth hormone is released during N3 sleep. And that happens in spurts of 7 to 9 minutes, 3 to 5 times a day. And if you have sleep fragmentation because you can't breathe, you don't have to have sleep apnea, you have to desaturate. But if you're a child that can't sleep very well, you're not going to have your full complement of growth hormone. And know when this is most important. It's during the growth epoch. So with that, let's have Barry go ahead and you continue.
So children like this all the who has named this research in the British Medical Journal facial. It is often accompanied by either breathing and open mouth posture. Either during the night, usually daytime problem associated with this too. You can't expect someone to be well during the day. All kinds of things keep them open, and this I don't body picture, but really stick an old this forward shoulders. To say that increase he's not doing well, breathing well, well, kind of an really it's almost a given that if you're not sleeping well, there will be systems of your body that won't perform. The needs that Muse had us, including orthodontics, help us to change the piece in a way that can relieve breathing, by bringing the forward, by bringing the teeth, opening stuff in the front of the and get more behind the soft palate. So why oral the nasal aperture, so that breathing is easier. And several years, you can certainly say that he has some in his anatomy, but compare him to his father, who was asleep and sometimes sleep and obesity, we have given this child a much better head start, and with better habits, now he's able to keep his lips together, breathe through his, keep his tongue on the roof of the mouth, learn how to swallow without having the facial, and up his future growth at this point forward in a much direction. Talk about the growth. Mark?
Yeah, I change it to the next slide. It's Carol Marcus and Company. This is just another reference, essentially underscoring what I previously said about growth hormone, that any kind of sleep perturbation is a problem for growth. And basically what she says is decreased growth secondary to increased caloric expenditure caused by increased work of breathing during sleep. So let me underscore that sleep disordered breathing is, although it's a sleep diagnosis, it's really a breathing problem. And sometimes we get that backwards. There's no question it starts as a breathing problem that perturbs sleep during a time where the airway is most vulnerable. If we go on to the next slide.
Gravitational forces.
Okay. So this is something that is interesting. Stupak and Park recently, and I don't see it up on my own screen, but I'll assume that we're talking about Stupak and Park's study where, as two ENTs at NYU, they wrote this review basically challenging the current orthodoxy, stating that the variation in the mid-face skeletal structure is seen as the original problem, not a downstream problem of sleep and breathing problems. And they're calling it the Guilleminault-musculoskeletal hypothesis, because Christian Guilleminault, he actually had demonstrated that 93% of children with existing sleep disordered breathing presented with craniofacial risk factors for the disorder, noting that the key finding was mouth breathing because of a constricted airway. Another way of saying this is that sleep disordered breathing is a downstream consequence of aberrant facial growth. It's kind of like saying that tooth crowding is a dental symptom of a shortened arch. There's not enough development. Actually, it's nature's solution, just like mouth breathing is a solution for a crowded airway when you can't breathe through the nose. So in this article, they actually show this illustration of the difference between mouth breathing and nose breathing. And when you're mouth breathing, it increases the collapsibility of the airway. We're supposed to be breathing through the nose 90 to 97% of the time. And so in their article, they get deeply into the details. In fact, this statement, going back to 1932 from the Royal Society, this is a group of physicians, basically say, as to the typical adenoid facies, it was a myth for which no evidence has ever been brought forward, and was a remarkable phase in the history of medicine that's been accepted as fact by practically the whole of the medical profession. I will argue this is where we are in dentistry. Medicine got it wrong, dentistry is getting it wrong. And it has to do with the way the system works and our lack of integration and our siloed thinking. And so instead of chasing disease and signs and symptoms, I think we really kind of need to step back. It's not a tooth problem. It's a facial growth problem that really starts in the third trimester of birth. So what I like to do is I like to share the story real quickly with a few minutes that we have to the next slide, Barry, on Brendan.
Actually, I'm going to bring Brendan up in a second, but make a point that protractive orthodontics sometimes may not be enough to take care of a problem, especially if a problem is started late. Girl came to me, complaints of sleep and breathing problems. She was approaching the end of her orthodontic treatment. Her orthodontic treatment looked like it was being done well. It started with crowding. She was uncrowded at this point. The jaws were widened. She had a palate expander. But if you get the CBCT, the the circumference of her airway, especially down by the base of her tongue, was still very narrow. So in ways, it's not so much what the teeth, but you're looking at of the skull, and also take into consideration these breathing problems, quality of problems for people. This quality of service looks at 11 different areas that can be addressed. They range from the competencies of breathing and posture and chewing and to some of the bigger body issues of posture and nutrition, looking at daytime and nighttime breathing and some of the other things that go along with it, and then the comorbidities of the aches and pains and behaviors that are so very common for a lot of children that are having trouble breathing well. For her, we diagnosticated a mandibular advancement device, part of the sleep dentistry armamentarium, and did breathing repatterning. And without changing the structure, we reduced them dramatically. So not only do we want to address anatomy, we want to address function, behavior thing too. Mark, you can talk about the Godoy, the new to the pathophysiology of limitation.
Well, basically, the point that I was going to make here is that the citation that you see here, the study that more than 30% of total sleep time with inspiratory flow limitation that was detected during the sleep studies was associated with nasal and palatal anatomic abnormalities in sleep disorders. So again, it's not about the teeth; it's about the orthopedic components that hold those teeth in place, what we call the fundamental components. And I think at this point, I could end with 3 clinical examples, if that's the case there. Barry, if you could put on the first slide.
There's Brendan.
And so I'll end with three cases. So this is my son some 10 years ago, and how I woke up to this whole problem. I had been treating adults for some time, but I never really saw kids. My practice is now, I didn't ask for this, but it happens to be now about 50% pediatric. And it wasn't until we were in the emergency room at 2 a.m, teetering, thinking that we were going to lose our son because he was desaturating down to 70%, and he had been misdiagnosed with asthma. But you could see the phenotype that's going on the wrong direction. If you go to the next slide, this is how he would sleep. And after he had been treated, whereas before he had an open mouth and his neck was hyperextended. Using high resolution pulse oximetry, when I measured it objectively, we could see that he had severe disease. And after just less than 3 months, around 2 months of BioBlock treatment, you could see how his apnea-hypopnea index plummeted, and why we teach how we want to measure this objectively. Otherwise, we're just guessing as to whether the patient's doing better. We want to make sure we're on the right path. Go on to the next slide, Barry, where you can see where he's sleeping prone, mouth is open. And then the next slide showing how his lips are together, he's breathing through the nose. And how he finished, you can see pro and post, the Bolton norm, how although it's not perfect, it's certainly a big improvement. And most importantly, all his symptoms of bedwetting and lack of energy and reflux, all of those symptoms were gone. That next slide, I can't see it, but it's a slide of where he is now in comparison to his dad. And you can see my long face. Look at my incisal edge position. I'm way too vertical, like everyone else on this call, pretty much. And we got to get it right for our kids. He has a much better incisal edge position to go along with, and facial balance to go along with all the health benefits. Our next slide quickly.
I'm going to interject here, Mark, with an example of a 9-year-old male who also had bedwetting and other parasomnias, including frequent nightmares and sleepwalking and trouble sleeping and so forth. You can see the thumbprint type palate. You can see the crossbite of the upper front teeth, the upper teeth being behind the lower ones. And we also measure his daytime breathing as well as his nighttime breathing. So we're looking at a breathing pattern that's somewhat irregular and doesn't and is indicative of someone who's over breathing in the sense that they tend to blow off too much carbon dioxide. The tops of those graphs measuring carbon dioxide should be reaching at least that bottom line there. And that becomes a habit that will influence the way oxygen is delivered. So we put him through light wire arch development, which is a technique that we use for kids that are in pre-bioblock stages. We taught him a bit about posture. We taught him about breathing. And you can see that we got some development of the maxilla such that the crossbite is gone. But within a fairly short period of time, he was able to learn not only how to breathe at a proper rate and volume, but it was enough to decrease the symptoms that he had. So here we've only made a modest anatomical change, but again, by addressing function and behavior, we're able to reduce the symptoms that were affecting his quality of life. Mark, we'll talk about...
real quick, I know our time is ending, so let me just finish real quick here. You can see this patient came into my office very late in the game, 10:30 to 11. You could see parents were concerned. Next slide. Couldn't bring his lips together, had a big interlabial gap. And the next slide, you can see that when he smiles, he showed 2.5 acres of gum. And I told the parents that if I reduced that by 50%, I would have hit it out of the park. And you can see here with the snarl, that's not really on the right, it's not really his smile. It improved a lot. But more importantly, go on to the next slide, Barry. Next couple of slides, you kind of go through the gallery. He had a huge improvement in his athletic ability, his daytime function, as reported by his parent. His dad's a physician, and his mom both reported that he did as well. Are you advancing, Barry?
That's the last one I have of that case. The next one shows an example of a bioblock.
Let's do it.
Yeah. The next one shows a 9-year-old girl who came in with a crowded dentition. Really finding room for the teeth is only part of what we do when we're trying to help children grow the best we can. And you can see we were not only able to find plenty of room for the space, but because of the demands of her face and her profile, we are actually finding extra space. The profile improves when you give the jaws a chance to come forward and to support good lip posture. And of course, we're making more room for the tongue and consequently better breathing behind. When we look at the validated questionnaires that we use to look at the symptoms of sleep, this is the sleep disorders inventory for students, one of 3 validated pediatric sleep questionnaires. This survey looks at breathing, at restlessness, at sleep rhythms and hygiene and behavior issues. We want to see these numbers decrease dramatically when we can open up the airway and improve breathing. But it's got to be done with not just with anatomy, but with function and behavior as well. And
last slides for me.
Yeah.
I won't get into the medical metrics, but it was huge for this child. But you can see just looking at the face, because form truly does follow function. And then look at her profile. And she's not done with treatment, but you could see that she's improved quite a bit. And so with this short period of time that we had, thanks for the opportunity to share on this panel discussion. I know it's kind of gotten late, so let's nix it at this point to get our
We
next.
have to move on to the next speaker.
Yes.
Let's just say this. These are the points that we're trying to bring forward, that forward facial growth enhances breathing, sleep, and overall health. That our goals are patient-centered quality of life improvement, and we need to measure the medical metrics to show to show our success.
Thank you.
Hello, folks. Am I on now? Okay. I got my slides here. I'm Dr. Ben Eastwood from Edmonton. I've been practicing BioBock orthotropics for 40 years since I met John Mew in 1981. Now my slides aren't advancing at all. Why not? I don't know what to say.
You need to advance the slide.
Need to advance which?
You need slides.
I'm trying to. It won't advance. Nothing's happening. I'm trying to advance, but I'm not getting any movement, folks. Okay, there we go. Thanks. These are some of the positive benefits that I see in my practice, facial, skeletal, nasal, oral, eliminate the need for surgery, encourage mouth breathing, oral impacts, reduction in sleep apnea, improvement in mental function and performance, impact on socialization and acceptance. That's a really big one. Changes in head posture, changes, preventing extractions and TMJ, helping TMJ. This is a young man that oh, what happened now? Now I'm gone again. Young man that I treated in 1998. He was 24 millimeters wide, and now he's 41 millimeters wide. I moved him up, and you can see the changes in his face, how his eyes have lifted, how his chin has come forward. He needed to have his tonsils and adenoids removed at 24 millimeters. It was the second smallest I've ever seen, intermolar, and when I finished, he didn't need them removed. Here he is 4 years later and completely stable with no retention. This is a young lady that came to me. She had a few issues. She had a tongue ring or a tongue piercing, and I told her I couldn't treat her with the tongue piercing, but she took it out so she could have treatment. Here she was to start. She had 9.7 millimeters of overjet. You can see the facial disharmony, some whites under the eyes and things that are there. And what we're looking for is symmetry, as they show in this biology of beauty study. Here she was before, and here she is after. This is just a recent picture in 2020. So it's just happened that I lined her all up, and you can see how beautiful the symmetry is, and the changes in the lips, the eyes, the cheeks are more symmetrical. It's really quite nice. The cheek line we look for parallel to the nose. As it starts dropping down and back, we're losing maxilla, and it gets really bad dropping down and back. We get the bump on the nose. Here she was to start, a little bit down and back and flat, a little bit of a higher jaw angle, chin retruded. And here she was when we finished. Jaw angle is improved, the nose nasal angle is improved, and her jaw has come forward nicely. There she is. You can see the nice cheek improvement. They're both about the same angle, and you can see the whites under the eyes have disappeared, and the cheek has come forward quite nicely. And she was 13 when we started. There she is when I finished. She looks very nice. Okay, I'm going to go very fast for this, folks. Here's a young lady that another doctor has been treating with me helping her. And if you can see the nasal passages when we started, she's had trouble with breathing and she's got an open mouth posture and things. She's not my patient. She's sleep disorder breathing in patients where you see low performing grade 1 students and they have trouble. That's not, we've all been talking about that. Here she is before, but she fell and displaced her front teeth and the bottom. So she went to the university hospital. They pushed him back in place, replaced the lower appliance, which was removable that we had to hold the teeth forward. And they took a pan and they sent the pan to us. And here she was after. That's 5.5 months. Now, most of the time, nobody takes a pan in 5.5 months, but you can see the dramatic changes in the nasal passages. And Mom said she was feeling better, sleeping better, doing all kinds of shit. She loved her appearance much more in 5 months. This is a young lady that was referred to me. She moved from one town to another, so Dr. Darren Ward sent her to me. She had all kinds of problems. Oropharyngeal constriction was one of the big ones. And this is where I received her. Darren gave her 3 treatment plans, and none of them were perfect, but she chose BioBlock. And here's where I got her. Now, some dentists will just freak right out when you see those teeth were really protruded. Now, Darren had her in a stage 3 appliance. And what do we need? We need stage 3 to keep the mouth closed and to get the muscle tone working. And we did. This was where I received her. I took the brackets off and it kept her in the stage 3 for a while. And then I switched her to a stage 4 once she started losing her baby teeth. This is where I finished her. This is 1 year post finishing her, a picture of her occlusion. And there's the occlusion on the bottom. And it really worked out well. This is her before picture, and this is her after picture, how nicely she has come forward. It's a dramatic change, and it's the definitive directional growth of change in Destiny. Before and after, and you can see the improvement in her airway and the improvement in the chin and everything. It's quite a lovely result. Here she was before, and here she is in 2018. And here she was 2 days ago when her mother sent me the picture, and I think her destiny is really determined. This young man was an interesting case. He had an open mouth posture. He had, a dramatic overbite and overjet, and Mom wanted me to do something for him. That's where he started at 8.5 years of age. This is where we got him when he's 10.5 years of age. It's not finished. He still has his baby teeth. It's mid-treatment, but there's a reason for this slide. Mid-treatment. Here he was when we started, and here he was in mid-treatment. We've moved his jaw forward nicely, and you can see the dramatic changes in his airway. But the real story is that Evan at 8 months of age could not swallow any solid food. He'd never swallowed anything, not even a grain of rice. He was treated endlessly for 9 years with medications, and he had 4 years of swallow practice at the Glen Rose Hospital without any success. He was fed blended foods for his whole life. He couldn't enjoy anything. He was referred to me, and after 1 year of BioBlock stages 1 and 2 and 7 months of stage 4, he started eating solid foods. Mom credits me, but there's many factors in play. Okay, now here he was moving forward at 12.6, and this is what he looks like now. We didn't stop a lot of the facial growth height, but he's still a nice man, and he's grown like a weed since he started eating at 10 years of age. There's his final, his start, and there's his final. Bolton norms, really quite nice. This young lady's a dramatic change too. She had an 11.6 millimeter overbite, and she was told that she needed surgery, and they weren't going to do anything for her till later on. I think she should have been treated sooner, but that doesn't happen. Who would let their kid grow like that? Well, lots of dentists do let the kids grow like that. And here she is. You got no chin. Okay. That's a big problem. Everybody knows where that airway's going. Here she was to start at 10 years of age, and here's where I got her at 13.4. Some people have asked, is that the same girl? And I said, yes, it is. Here's her before picture, and here's her after. You can see the improvement in the airway. You saw the improvement in the face. Here she is. She's got some beautiful symmetry, just like the rest that we saw earlier. The diastema there, I closed it with some brackets for 4 months, but it opened right back up, tongue posture. Okay, so here she was before, and here she is after. There's dramatic change for this woman's life. No root loss, something that doesn't happen. A man only hears what he wants to hear. He disregards the rest. That's what we've all been talking about. People have got to hear what's going on. Younger children are good candidates for phase 1 ortho. They have good self-esteem. By age 8, they understand the criteria for attractiveness. So why would we wait to treat them? Here she is. Maybe the years will be kinder to her. She was 4 years older. The psychology of this picture, she only started to smile at this point. That was 4 years after I gave her her smile. That's a tough one. This young man, lovely young man, big changes. 4 years of changes. You can see the change in his bites. You can see the changes in his face, but that's not why I brought it. Here he is profile-wise. You can see how his chin has come forward nicely. His cheeks have filled in nicely. You can see that he's got a nice class 1 bite. A distalized maxilla is a factor in sleep apnea. Could BioBlock be an answer? Here he was to start. Look at that dramatic angle of the spine and the flat face. Here he was when we finished. Now his airway doesn't look bigger, but he certainly has a much better posture. And you can see how nicely his maxilla came forward and his sinuses, his frontal sinus, everything is opened up. This is a young lady, I'd call her, by my standards. She had quite a bit of overjet and overbite, and she had a TMD problem. And she asked if I could work with her. And I said, okay, I'm happy to work with you. Here we have the teeth coming forward. You know, that's where I got her to. I had her in some braces for the bottom, not for the top. I did mostly BioBlock, okay? Here she was before. Now she's a grandma. When you see this final picture, she has 9 grandkids. And you can see the dramatic change in how her jaw came forward and the dramatic change in her airway. Can you do it for older folks? I guess you can, because it certainly worked for her. And she looks wonderful after. No root loss, again, with orthodontics, okay? She says that she thanks me for everything. She says her husband thanks me because she doesn't snore anymore. So that's a good sign. Now, this young lady, 37 years of age, clicking jaw, locking jaw, constantly, daily, almost daily headaches, every second day for sure. She had 4 bicuspid extractions and 20 years of discomfort. Maybe it was 21. She's 37 now because she said she was 16 when she had her braces off. So we said, okay, I think we can help you. So we expanded her and we brought her to here. You can see facial changes. She says she's doing awesome. Her jaw stopped clicking. Her jaw stopped locking. She rarely has headaches, and we reduced her snoring. There was her first picture. You can see the nasolabial angle is quite steep after her. Now we brought it forward. You can see the spaces that we've opened. She got those fixed down south. She came about 120 miles to see me every time. She was only 15 months in treatment from 03 to 05. The final pictures here and here, you can see the difference between before and after. It looks like she had a facelift, but she didn't. But she's not in pain anymore. Here was her before airway and here was her after airway. You can see how nicely her jaws come forward and that spinal angle has changed just a little bit. Some of the sinuses have opened up a little bit more. So I think she's a happy camper, you know, I just show that. And I went really, really quickly. I'm sorry for everybody, but we got a little bit behind. There we go. Some more airway and sinus changes. So that's the end. I'm really happy to have been invited to this, and I hope John Mew and the boys that you keep doing what you're doing, and thank you very much for teaching me, and thanks. I'm done with that. I gave you the end, but it's not the end, it's only the beginning. I hope this changes world for a lot of people. So we can go on to the next speaker if you guys would like. If I know, we'll answer questions when the questions come.
Hi, do I have my screen now? Yes. Yes. My name is Karen Gatt. I'm a professor at the University of Paris 8. I'm speaking here on extraction consequences, and I feel very grateful to be with these great doctors and researchers on this program. And I myself am a researcher in cinema and in neuroscience, and spent 10 years doing research and interviews on film directors. And so you might wonder why I'm actually in this program. And the reason I'm in this program is because 3 years ago, I had to completely stop all my research in film, all my journalism at film festivals, and had to completely change my life and become a researcher in extraction orthodontic consequences. I also would like to ask that you forgive the way I'm speaking. I have a big speech deficit, and as you will find out later in this program, why it is that I have this speech problem is related to extraction orthodontics. I'd like to turn to my PowerPoint, which I believe, can you see my PowerPoint? Is it not sharing? Is my PowerPoint not sharing? It's not here. Hello?
Karen, we're waiting for you to advance your slide. Nothing will appear until you advance your slides.
Okay, it just turned off. I see what happened. Okay.
You turned it off. You turned it off.
I didn't turn it off. It's absolutely, it just disappeared. It disappeared.
Okay, can you just share it again?
I'm trying. It's not letting it come up now. Is it possible for you to share it from your end?
No. You'll have to talk without slides as you got rid of it.
Oh my goodness. Okay. I didn't get rid of it. It just disappeared. Okay. I will try one last time. Okay. Not showing. Okay.
Just share your screen. If you share your screen.
Yes, but when it allows, oh, here it comes back. Okay, here it is. Okay, here it is. Is it on now?
Yes, we can now share your slide.
Great, thank you.
Okay.
Thank you.
Don't drop it again.
I'm not dropping anything. It's just dropping by itself. And I will go through the slides myself then. Okay. What I'd like to do is share the results of my research. And the results of my research that I've done for 3 years is, first of all, I'm speaking to a general audience right now. I'm not speaking to the doctors and specialists on this program who know all this. I'm speaking to people out there who might not know the basics of how extraction orthodontics affect the body. I have a YouTube video, but I'm afraid I won't be able to show it. But here is this video that shows exactly how when you take out 4 premolar teeth, which is a basic procedure in up to 80% of orthodontic
we have your video. We can play it now if you want.
Yeah, play it now, please. Play it now,
Okay.
and I will speak while you do that.
Okay.
Extractions are a basic procedure used in up to 80% of all orthodontic cases, especially in Asia. Today in Asia, it's up to 80%. In the United States, it's down supposedly to 25%. And that because of the 1986 Brim lawsuit, in which a woman won $1.3 million against orthodontists for the mutilation of her jaws that was caused by her extraction retraction orthodontics. After 1986, extraction rates went down in the United States by half. And what happens, you see here exactly what happens. When they extract teeth and then start retracting it back with elastic bands or with aligners or with headgear, with tags, what happens is the alveolar bone, which is part of the jawbone, it's pushed back as well. For every tooth that's taken out, you lose 7 millimeters of jawbone permanently. It's resorbed into the bloodstream. And then afterwards, the whole mouth becomes smaller by 3 centimeters. And what can happen then, the jaws will grow less forward, as people here have very well explained. And when the jaws grow less forward, that means the maxilla falls back, the mandible retrudes, the nasolabial angle increases, there is a decrease in upper lip vermilion, the upper lips retract 2 to 3 millimeters, and the lower lip retracts 1 to 4.5 millimeters. This is such standard result of extraction retraction orthodontics that it is a method of choice to treat patients with maxillary protrusion, bimaxillary protrusion. And in fact, these facts that I'm getting about what happens to the mouth, the smaller jaws, protrusion, it's coming from research articles about why extractions is a successful choice for people who have protruding maxillas. So this is a predictable result. Now I'm going to go back to my PowerPoint. If we can go back to my PowerPoint here. Do you see my PowerPoint? We're done with that video. I think that video has done its here. So here is the permanent loss of 7 millimeters of jawbone. Extraction people who are listening to me, and I'm speaking to extraction patients today because there are many people out there. If it was 50% of people in my generation who had extractions with orthodontics, that means that 50% of you have had these consequences. You have lost 7 millimeters of jawbone for every tooth that you have extracted. In orthodontic literature, this fact does not come up. It comes up in periodontic literature. In periodontic literature, it's a staple. You can find hundreds of articles about how you lose permanently the jawbone with extraction. Then what happens, I will go to my next slide here, the jaws grow less forward. Again, what I was saying before about how the lips go back. So people who have extractions, you might notice that your lips got thinner and your lips became more back in your face, okay? Your nasolabial line, which the doctors here on this program can much better explain these details than I do, but the nasolabial line will increase, which means your face will angle more back. This will cause all these maxilla mandible retrusion will cause a recessed profile. Then I'll go to the next slide. I'm so glad this is working. The dental arch is narrow. The dental arch is narrow because when you push back the teeth, as you see in that video, when you have less teeth and you're trying to close those spaces, the arch itself becomes narrow. Now, this is reported in every orthodontic article, including by the American Association of Orthodontics. This is reported to reduce the intermolar width. The arches get narrow. That's why you see buccal corridors, and that's people who don't know that term. It means dark spaces at the sides of the smile because the arch has become narrower. the palate narrows and shrinks because the arches are what determine how big and wide the palate is. So if you have a narrow arch, your palate is obviously narrower. Then what happens is the possible negative health consequences. People have discussed it here in much more detail. I'm giving a layman, a professor view of what these consequences are in fast forward. Insufficient space for the tongue on the palate, reduced airway, obstructive sleep apnea, which can come because the tongue is blocking the epiglottis, because the tongue has no space in the mouth to fit on the palate, so it has to go hide somewhere, and it hides in the back of the throat, or it lies low in low rest tongue posture. You can get TMD or clicking TMJ. In fact, many patients report that the clicking of their TMJ joints is the first symptom that they notice. Tinnitus can result from the TMD. It's somatic tinnitus. It's from the jaw muscle strain next to the ears, right? That the jaw muscles are right next to the ear. Then there can be, and it often is, according to my research, neck skull misalignment and chronic neck pain and difficulty with posture. In the next slide, are you seeing my slides? I'm not sure you're seeing my slides, but I'm pretending that you do. The negative aesthetic consequences are usually apparent quite quickly. In adolescence, you'll see it immediately. The profile gets dished in or flattened because the jaw bones have gone in. As one ages, people who might be happy with their extraction orthodontics now might not be so happy when they hit age 40 or even 35. They will see that because they have less bone and because they have less tooth support, the soft tissue, which means your lips and your cheeks and your skin, is going to collapse, and you'll have more wrinkles, you'll have sagging. Your lips will get thin, but they already did get thin once you had those extractions, but they'll get thinner as you get older. Sagging, premature aging, that's a standard. Pronounced nasolabial folds, that's what these are. Folds in the neck skin, because when your chin goes back, this part of your neck starts sagging. You might have something that looks like a bump in your nose, which is not a bump, but it's because when things go back, the nose has less support. Dr. Hank can explain it much better than I do. Slumping posture is because when your mandible is back and it's not in the right alignment with your cervical spine. That's one reason. Another reason is a lot of people who have had extractions develop a habit when they're 14, 15 years old of tilting their neck up, tilting their chin up, because they have to open the airway and breathe. Well, if you do that for 20 years, you're going to get chronic neck pain. Chronic neck pain, and your posture, using this kind of posture, is going to be like this. And that can get extremely bad as you get older. Then there can also be asymmetries in the skeleton, because any shifts, I think Dr. I think there's an excellent chapter on this in Granville Smith's book on Is Your Bite Correct? And he speaks about how changes in the jaws, if they become asymmetrical, which they can become due to extraction orthodontics. That's another consequence that's been observed. It will follow through and trickle down through your whole spine, and you might have one leg longer than the other. You might have your hips, one hip rotate in a different direction. And now to go to where I really want to speak about is here are some examples. I'm speaking to a layperson here. That's why I have circles. You see, this is a woman who as a child had her extractions, very young, at age 7. And look at her, I have these circles here because the people who might not be trained to look at these x-rays can see that's an airway. And that's an airway. And see how the jaw completely collapses back. Now, this is this woman now in her 40s. This woman now has extreme neck pain, extreme jaw pain, can only trained as a musician and can only work one day a week teaching children music because she cannot play music because her neck and her spine cannot support the instrument. Here is a young boy who in Spain had a beautifully growing forward face in this early child picture, had braces and extractions in the second picture, and this is him today with sleep apnea, and so tired that every day is a struggle. And here is this woman is a wonderful woman, first of all, but also a wonderful example that we don't need twins to see whether extractions really cause this destruction I'm talking about. Professor John New did an excellent case study of twins back in the 1990s, where he showed a before and after set of twins, where he took one twin and treated his twin with orthotropic forward face growing methods, and the other twin was treated with extractions. Well, one twin had his face collapse back like these other people, and the other twin had a forward face, a handsome face. Dr. Mew had confided to me that this was the only way to get evidence of how extraction orthodontics affects the face, because anybody could say, well, if a child later gets a face that's collapsed, that's the way he was genetically. That's the way he was going to be anyway. There is no proof. And here is proof. Here's a woman in her early 30s. The first picture is her at age 30, before she decided to get extraction orthodontics. The second picture is her 2 years later. You can see how her face got thinner. You can see the holes at the side of her smile, which is the buccal corridors. And you can also see that her face went back. She doesn't have that full face anymore. Her nose looks bigger. Her smile looks smaller. And we have a comparison in the next. And here we have me. Okay, here is me. The first two pictures are age 11, 10. I'm an unusual case because I actually didn't even really need orthodontics at all. I had straight teeth. An orthodontist just said that my 4 premolar teeth were impacted. All 4 were impacted, which in dental history has doesn't exist. You cannot have 4 impacted first premolars. Well, he took them out, and you see me 2 years later, how the bottom of my face is slanted in. My smile is smaller. You cannot see my top teeth. You see buccal corridors, the dark circles at the sides of the smile, and you see my neck has changed. I'm tilting up my neck, and you can see that I am doing that. Well, you can't see that I'm telling you this, because that's the only way I can breathe. When this happened to me, I was devastated. But this is me 3 years ago. I was devastated for the aesthetic consequences. I didn't think about it again until 3 years ago, when my entire health collapsed. When I say collapsed, I got every symptom I listed on that health I got the extreme TMD to the point that I had to have my muscles of my face Botoxed and paralyzed. I had inability to swallow. I had neck pain. I, at one point, stopped working at a desk and started working from bed because I could not support my skull. I had such extreme speech difficulty that I had to stop my journalism, and teaching became a feat of what I consider heroism. And
Karen, what did you do about your treatment? Tell us what you did.
Oh, what have I done to treat it? Well, I don't know if you can. I'll go back to my. That's exactly what I'll tell you.
We're out of time for your presentation, but maybe just a quick summary of what you have done.
This is exactly where I wanted to go. I'm glad you reminded me. I live in Paris, France. In Paris, France, the consequences of retraction and retraction are not recognized. It's recognized by jaw surgeons. I saw 25 orthodontists in Paris. I saw 40 in New York. I saw 10.
We lost the connection, Karen. We're having a hard time hearing you. The sound's breaking up. Yeah, the sound's breaking up, Karen. We couldn't understand what you said.
Right, let's move on to the next question and answer section. Are the panelists ready for other questions? So, Brian, do you want to read out the question?
Sure. The question is, I need an orthodontist in Arizona who practices the Mew method. I'm an adult who would like to move my jaw forward a bit, open up the airways, the tongue and neck tension. There's a group called the North American Association of Facial Orthotropics, NAAFO. I recommend that you search for that online, orthotropics-na.org, and look for the Find a Doctor section and see if there's someone in your area or who might be closest to you.
Another question here.
Is it possible to reopen the spaces from wisdom teeth removal after having bicuspid removal, basically 8 teeth removed? I want to address that.
I don't know that it's possible. I don't know that anyone else has ever been able to do that. I get that question all the time. I have not tried it. I frankly don't know the advantage of if it were able to be done.
I don't want to have it.
Reopening the molar spaces, that is, not the bicuspid. The bicuspid we do all the time.
I would suggest that we stop looking at the teeth. What's what's the diagnosis? I mean, we have to be careful and find out what needs to be done. What's the problem?
Here's a question. I'm 16 years old. I have an overbite, weak jaw, narrow palate, and a flat face. What are my options? Well, whatever you do, don't extract and retract. That's not likely to be the best option at all, but see someone who's open to decreasing your tongue space and pulling things backward. But that's going to be a big temptation no matter what you have done, because whenever you have an overbite, the temptation is to pull the upper backward, even without extractions. That's a very common treatment. Even with treatments that say that they're bringing the lower jaw forward, the result is often pulling the upper jaw backward with what we call a headgear effect. So be very careful of anything like class 2 elastic, Herb's twin block, forceps, whatever. There are a lot of different mechanics that will all tend to pull the upper backward. In cases like yours, try to avoid those. One option for some people has been to simply compensate for it by bringing the lower front teeth forward a little bit and make it look like they're a little further forward, but the lower jaw still stays back. So without seeing the case, it's hard to say a lot more specific. Anyone else?
There's another question here from Tim.
Does wisdom teeth extraction cause the same issue as bicuspid extraction?
So if you believe the evidence, Kristen Guilleneau did a study showing that if you're extracting third molars before the mid-20s, that you have an adverse effect on the airway. So I think we need to be careful about nucleation and remembering that it holds bone and that supports the airway. So I'm not going to say that it has the same effect, but it's not airway positive.
It does seem like when the wisdom teeth are left in, the jaw seems to grow more in the back. So better to keep them if you can. How many millimeters of maxilla growth is possible from mewing after 18? Maybe John Mew can answer that.
Well, it's very hard to say what is possible, but I will say I've been absolutely amazed at the amount of forward growth some people have achieved by mewing. Even after they're 20, even when they are 30, you will still get some forward growth if they mew determinedly enough. And that really means doing it all night as well as all day. But of course, that has to be a change in subconscious posture, which is asking quite a bit.
Next question is, what do you think about reopening extraction spaces and then moving all the teeth, including the wisdom teeth, forward, I assume, to fill the space instead of getting implants? This is a treatment that has been possible for some people using what they call skeletal anchorage, little mini implants to pull forward the teeth behind the space after it's been opened. Anyone else want to comment on that? I see Bill Hang is not on here, and I know he has done that kind of treatment.
Yeah, I think I like to think of it as, instead of saying reopening extraction spaces, developing the dental alveolar and alveolo-skeletal fundamental components. In other words, you're deconstricting. And it will result in opening up spaces per se, but thinking about it less about the teeth and more about creating more oral volume. And it's possible with a number of different techniques.
How about this? Is it possible to get jawbone back that is lost from extractions?
I would say so. I mean, you've seen it in some of the slides today, but I mean, again, we have to look at each case individually, and like Bill said, it's until you get more information, you really can't say whether that person's going to get it. I showed you. I hope my slides got to the older ladies that you saw quite a bit of change in their jaws, and you opened it up. Now, whether that jaw actually grew, I can't tell you. I don't think so, but certainly we got room without destroying anything and without losing any bone or without losing any roots. So I guess it is possible, but we're at some of the questions we can't answer because there's not enough information.
Some people want to know if the exact same configuration of their jaw is going to come back when spaces are reopened. And I don't think that's the case. You will get more room. Like Mark said, that's the most important thing. And you do get more bone. I mean, we can put implants in the spaces that are created between teeth. So yes, more bone is created, but it's still not exactly the same as it was before the extractions. What's the best protocol for someone in their mid-20s for mewing to create the best feasible results?
Maybe John would take that one.
I'm not supposed to answer all these questions. I wouldn't say there's a protocol other than the simple rule of keeping the tongue on the palate, the lips in contact, and the teeth in or near contact. That is all you need to do. The one other thing I mention is that when you swallow, your tongue must not touch the teeth. That is what so many people do and spoils the whole effect of mewing. When you swallow, don't suck on the teeth. Don't touch them at all.
Maybe, John, for anybody who's watching that doesn't know what mewing is, you could explain it.
Well, basically, I put forward a hypothesis in 1981, which was called the tropic premise, which simply said that if you keep your tongue on your palate with your mouth closed and your teeth in or near contact, then your face and your teeth will grow correctly. And it was only fairly recently that some people, I think encouraged by my son Michael, decided to try it. And I have been, as I said before, absolutely amazed at the big changes they achieve, some of them as early as 14 years old, but often over 25.
There's a question for Dr. Cruz.
Dr. Cruz, what do you think of the anterior growth guidance appliance for remodeling and growing the maxilla of adults?
So I'll just say, I'll answer this question by saying that I am agnostic about the tool that's used. And it's more about what the outcome is. There are many devices that are out there that can certainly facilitate our goals, AGA being one of them, no question. But I've also seen some of these appliances that have been misused, and someone that applies the wrong forces that are less orthopedic in nature, which is what the AGA wants to do, and they're more dental and orthodontic in nature, and that they could push the teeth off the bone. So I think it can work. I want to remain agnostic about it and more focused on the outcome. And so there are many things that can work out there. Just have to know what the goals are.
Next question is, my orthodontist wants to reopen premolar extraction by moving wisdom teeth backward. The upper jaw has enough space, but the lower doesn't. So what's the correct move here?
You need it. You need info. We need a workup. It's hard to answer that question without, just.
I think in general, backward is not as good as forward. And also, how are you going to move the back teeth backward without pushing forward on the front teeth? You're probably going to get both, but it might be because your orthodontist is afraid, or he's been told you're going to push the teeth off the bone if you try to bring the front tooth forward. And if it's under that misconception, maybe there's a problem with the treatment plan overall. What is better, splitting the suture and MSE or stretching it, like with the BioBlock DNA, et cetera? Anyone want to answer that?
I'll just suggest again, it depends on what the goal is. So we have to understand that the three fundamental components that we're dealing with craniofacially. It's the cranial base of the skeleton. There's the dental alveolar complex, that's the bone that houses the teeth directly, and the alveolo-skeletal fundamental component that connects the two. And so they behave differently. Micro screw expansion can certainly help in females up to the 6th decade of life, males not much later than 38 years of life. It starts becoming less predictable, and you can actually address the transverse deficiency, but is that really what we want to do if it's an AP problem? Maybe, maybe not. We have to understand.
What he's saying when he says AP problem, Dr. Cruz means a front to back problem, but the forward growth not being good enough, and trying to solve that, as Bill Hang says, with a side to side solution might be missing another whole dimension. Barry, you want to add anything to that? Or Ben?
Nope.
What are the thoughts of Invisalign?
I think I'm sorry. I on that last question. I think it's a very interesting question because we learn about biology, the more understand the environment is its growth, and reverse some of the growth changes by keeping the environment and helping nature take its course in healing the body and reestablishing bone growth. But sometimes people are in such distress that we need to apply a little more direct treatment to help regain lost, to help get good function going on. So both of those have their place. Remodel the expansion, and I think it'll be the discussion of these next decades as to the cons of each.
I would say that there's a place for both, and it depends on the patient.
Yeah.
So next question is, what are your thoughts on Invisalign when one has had extractions?
I say a little bit about that. Dr. Albiali, who works in conjunction with Invisalign quite a bit, and he's been trying to teach them to get some forward development of the face. He says you can't correct the class 2 unless you get some of that forward development. But I think it's still at its infancy. So I'm not sure that you could do that to open extraction spaces. If you did, it would be a very long and protracted case. And I often see in Invisalign cases posterior open bites, which concern me quite a bit. It's I don't say they all happen, but those are some of the things that I've seen with it, and I know that I really respect Dr. Albiali. He's done some wonderful work, but it's still in its infancy.
I've had multiple cases where I've reopened the extraction spaces using a removable appliance and then going into Invisalign to align the teeth and to align the roots. And I'll just say that it's extremely challenging. And it's if you tied one of my hands behind my back, I might be able to do everything easier. So it's really not the best way to go, given my personal preferences.
I'll suggest, first of all, John, did you want to go?
In my view about Invisalign is that they are excellent at aligning the teeth. They are not really very effective at aligning the jaws. In fact, from time to time, you will get what they call yaw or tilt, and the alignment of the jaws will go completely wrong. And of course, orthodontists have no way of restoring that afterwards. And so there are quite a number of legal cases arising where the teeth are beautifully straight, but they just don't meet properly at all.
I'll just, first of all, like to say, I like to use the term clear aligner. Again, in remaining agnostic, there are a number of companies that make clear aligners, and it really comes down to understanding a few things. One, the ClinCheck, and two, what approach you take. So I use it routinely using corticotomies to develop dental alveolar and alveolo-skeletal components in preparation for maxillomandibular advancement surgery. So we use Invisalign for MMA, but you could also use it to dramatically increase oral volume in a very, very short period of time. But the biology is very different than PDL-mediated tooth movement. And so it's a big discussion, but you can use clear aligners to do that very, very well.
Do we have any other questions to put up, Bill?
We're just looking for more questions. We'll see what we've got. There's somebody, this question we've had a number of times, somebody looking for somebody in Turkey. I'm not sure if we can point them in the direction of anyone in that region. Somebody asking here about what the other alternatives are.
Well, it depends on what you're talking about. That's too general of a question to really give you any meaningful answer.
I would say that a lot of people doing internet research focus on appliances, and they think solve their, and that find some do that. But really, I think we'll advise that you need to do at the goals of your treatment, which are appliance dependent. What you need for the structure and behavior, and then choose appliances that might fit the bill.
Yeah, it's kind of like saying, you know, do crowns, composites, and veneers, can they improve my smile? I mean, it really depends. You need a diagnosis. That's why you need a doctor to come in and have a comprehensive examination.
Can my orthodontist or ortho move my teeth forward after he extracted 4 premolars?
Is that
Bill Hay, you want to answer that?
This is a question that I get all the time, and my response is, I think you should talk to your orthodontist about it. If what you're saying is, did you want your faces reopened? Expect that the answer is going to be no, and the patient will likely tell you that you'll push the teeth off of the bone support. And I would suggest to you that you might ask the person to show you a case where that has actually happened, and not something that he or she thinks will happen, but something to show you an actual case where it has happened. I'm unaware of anyone who might even have that kind of a case. Again, you can't, not every patient who's had teeth taken out is a candidate for reopening his faces. You must look at what's going on. What are you attempting to accomplish? Where are your jaws? It's a hypothetical question that I can't really answer.
Could I make a point on that? Quite frequently, I too have come across cases where premolars have been removed, they've started treatment, they don't like what is happening, and they come and say, what can I do? I actually say you have a choice. Either you finish with your teeth beautifully straight but set back, in which case your face will not look so good, or you can take them forward, but you will have spaces, but your face will look better. And I leave the choice to them.
We have another question here.
Next question is, supernumerary wisdom teeth. Do you believe that could be considered one of the rare situations that could justify dental extractions when it comes to wisdoms? I'm not so sure that I would say that there are rare situations that can justify extraction of wisdom teeth. I think there are a lot of situations in our world today where you have to justify removing wisdom teeth for the health of the patient. So, and supernumerary teeth obviously can be even more of a problem if there isn't room for them and if they're causing problems. Anyone else want to comment on that?
Well said, Rod.
I have an asymmetric jaw from my teeth alignment. If I use Invisalign, will it make it symmetrical or just mess it up more? I just had my wisdom teeth removed last year too, by the way. So anyone here think that Invisalign could make the jaw asymmetry better?
Again, what John said a bit earlier, you know, the yaw and the things can change. And I don't know. That's where you'd have to know what the function is of that person. If it is really not very good, the answer would be yes, because the forces, just because you put Invisalign on, that doesn't change the functional forces. And if they are pulling upon the Invisalign, it could considerably change things. And, you know, but that's something that I don't have experience with, but it's how I feel.
You're not, so Ben, you're saying you think the Invisalign could correct the jaw asymmetry?
No, I don't know if it would. You know, like Mark and Bill have said, we have to have a diagnosis first. And you know, what I see, and maybe you guys do too, that our dentistry in general, if you ask people who look for proper function and a proper swallow and everything, I think in my city, I'm going to say 99.8% don't pay any attention to it at all for any reason, whether it be prosthodontics, whether it be orthodontics, whether it be anything. It's just basically ignored. And you can't ignore that, especially if you have an Invisalign case in there. If you're resting your tongue between your teeth while you're doing Invisalign, it's not going to do what it's supposed to.
Well, unless anyone has any closing comments, it's 4:45 now. We had planned to go until now. Thank you to Bill Mew for the technical end of making this work, and for John and Mike Mew for inspiring, as usual, the internet communication of all these topics. Thanks to everyone else, the presenters, and have a great evening.
A wonderful day by all. Thanks.
Thank you, Brian, for chairing. You did a good job.
You certainly did.
Thank you. Have a good night.
Thanks
Bye-bye.
to John.